Hi there, I'm Tara Mastracci. I'm one of the vascular surgeons at Bart's Hospital in London, and I'm at the PVI in Paris with my friend.
Tim Resch. I'm professor of vascular surgery in Copenhagen, Denmark. And we just had a little debate on percutaneous or open approaches to endo arches. Yeah.
Tim took the pro-percutaneous side, and I took the reasonably anti-percutaneous side. So I'm going to ask you, Tim, because you have more experience than I do. For someone who wants to start doing percutaneous, how would you recommend going about it? And how did you get into being so pro-percutaneous?
I think you start where it's easiest and safest. So start in the groins. Do the groins, learn to do percutaneous groins well. And then I would probably say if you're going to use it for the upper neck vessel area, I would start with axillary approaches. Be safe, have a bailout, use a secondary access if you need to use a balloon. Be prepared to possibly stent that, but get really safe here, then do this, and then possibly venture into the carotid. But that's really the last resort, because I think most of the time, for most vascular surgeons, you're safe with doing a cut down, so maybe that. But I think, Tara, there are situations when I don't do percutaneous either. When would you not consider doing percutaneous at all?
Well, I think all the sins of the arteries that we know in the femorals are probably similar in the carotid and subclavian. So if you had a really calcified vessel, if there was a ton of scar around it, or if you have distal stenosis that you're worried about, or a lot of atheroma in the vessel, these are times when I would probably really want to do open surgery just to be super careful.
Yeah, and it's good. It could be good for embolic protection, of course, I think.
Yeah.
You put a clamp on the carotid if there's a lot of thrombus material in the arch. But I think we both agree that percutaneous approaches are probably good for the patients when they work well.
Absolutely.
Cuts down the postoperative course and the risk of bleeding. And it's always important to keep in mind that even though we're vascular surgeons and it's comfortable to cut down, it's not without risk.
Yeah.
As is percutaneous, I guess.
No, I completely agree with you. When it works really well.
Yeah.
And we get patients out of beds so that we can do more patients.
Yeah.
So
I think it all comes down to patient selection, individualized decision making, and
health of the artery.
Health of the artery, yeah. So we agree on that.
Thank you.
Well, thanks a lot. It's great being. We're going to go on to the sessions.
Thank you.